I'm Sage.
And I'm Devin.
And we represent ImageRx. We're excited to tell you a little bit about our journey as a startup. Radiology lets us diagnose and treat diseases that would ordinarily be hidden from sight. In the United States, 40 million MRI scans and 80 million CT scans are taken every year, up from just 3 million in 1980. But not only that, the number of images taken per scan is also increasing, from around 100 in 1999 to 500 in 2010. Today, that number can be as high as 1,000 images per scan. It's no wonder there's a growing burden on radiologists. In 2015, the Mayo Clinic estimated that radiologists need to examine one image every 3 to 4 seconds. While staffing is increasing, it has not kept up with demand. But to really understand what it's like to be a radiologist, we need to talk about the invisible gorilla, a psychological effect first discovered in a famous experiment over 20 years ago. Participants watch a video where two teams are passing a ball and are asked to count how many times the players in the white shirts make a pass. But halfway through, a gorilla walks into the game, pounds his chest, and leaves. It may be hard to believe, but when asked, "Did you see the gorilla?" less than 50% of participants say that they did. Our intuition is that we will notice something that's that distinctive, that's that visible, but that intuition is consistently wrong and sometimes tragic. To be a radiologist is to live every day in this experiment. Every medical image has an intended purpose for which it was acquired, but not always are the diagnoses correlated with the intended purpose for imaging. These are called incidental findings, and if caught early enough, can save lives. But just like the participants in that study, radiologists must be laser focused on searching for what they've been asked to find, and often the invisible gorillas inside us go unnoticed. Sometimes this means missing a hard-to-spot blood clot in a CT scan, but other times it can mean missing something as obvious as a collapsed lung. If radiologist errors are indeed inevitable, then it is critical that we develop the technology needed to better support them in their work. For this reason, we founded ImageRx. We leverage AI to review standard of care images in medical image systems today and enable clinicians to derive data-driven insights in an unprecedented manner that drill down to the root cause of the clinical issues at hand. All our models detect rare diseases underpinned on structural abnormalities evidenced in standard of care images such as those taken with CT or MRI. Often deadly, abdominal aortic aneurysms, peripheral artery disease, Alzheimer's disease, and cardioembolic stroke are predicated by changes in the geometry, shape, and appearance of anatomical regions. Born out of over a decade of research at Pittsburgh-based IT and engineering service company QuantMD in the Menon Research Lab, with funding from the likes of the NIH, the NSF, and the AHA, and many others, ImageRx's unique experience has been foundational to the flagship technologies that we will go to market with. At its core, ImageRx is developed upon platform technology to identify structural abnormalities in medical images specific to diseased states, without explicitly requiring a physician to delineate the regions that may be problematic. We plan to go to market with trained AI, which has undergone rigorous peer review via retrospective clinical studies that have demonstrated not only the safety and efficacy, but also the precision and sensitivity to diseases that can alert clinicians to the gorilla in the images that may have been collected for entirely unrelated purposes as part of standard of care imaging.
Our flagship models will be trained to identify aneurysms, peripheral artery disease via CT angiographs with runoff, Alzheimer's disease via changes in the structural format of the medial temporal lobe via T1 weighted images, and finally stroke also via CT angiographs. Exemplifying the heart of ImageRx technology as a tool and a partner to the radiologist, we have collaborated with Raj Shah and Luke Higgins of Guidewire RX, which is a medical device company who seeks to treat peripheral artery disease. Working with them, we will implement our PadNet model into a clinical workflow that behooves the automated localization of peripheral artery disease in CT angiographs. Peer review is a big part of getting acceptance and buy-in from the medical community. Our constant presence in high-profile conferences as well as peer-reviewed publications with our partners is going to be the key to gaining this acceptance and buy-in from the medical community. We will also be applying for CPT codes. These CPT codes will allow medical reimbursement of the use of our product in the format of technological services as a supplement to standard of care imaging. We will also, as necessary, apply for FDA approval for our models through a 510(k) pathway. In the immediate future, right now, we have applied for various grants, including AI and aging for our work with Alzheimer's disease, as well as the NIH's SBIR. These grants are going to help offset R&D costs over the next year, as well as cover immediate regulatory expenses associated with the 510(k). And finally, we propose a 3-tiered flexible business model that will allow us to target the key players in the AI-based medical imaging field. The first tier of this model licensing focuses on therapeutic companies who are looking to non-exclusively license our applications for use in software pipelines to detect diseases they already have treatments for. The second set will focus on independent radiology practices and allow them, as well as imaging centers, to have constant access to our tools using an annual fee. And then finally, our last tier will allow access to our AI tools from labs and contract organizations on a study per study basis for a flat rate of $100 per study.
By 2025, the world market for AI in medical imaging is expected to reach $1.2 billion, with a compounding annual growth rate of 26%. Thank you.
Thank you for your time.
Tell us a little bit about what competitors there are out there using AI in imaging to identify similar problems.
Yeah, there are several companies using AI to detect certain rare diseases. These are Nanox AI is an example, Lunit AI. On average, this class of companies have existed for about 7 years with an average total revenue of 60 million. Most are private. And this technology has been applied to breast cancer detection, arterial calcification.
The biggest difference between other companies and our product is instead of focusing on a single disease that we can replace the radiologist for, we are looking to work with the radiologist and be his partner. And instead of just having a single model that can detect one thing, we're going to have a variety of models and tools so that the radiologist is informed of everything that can be happening in the scan as he's reading it.
So I loved your analogy of the gorilla. That's just phenomenal. And so as a layperson, that would be really helpful for me if you could tell me how your technology is going to help me see that gorilla.
So numbers are scarce, but the best estimate comes from a 2018 study. In 44% of cases where there was an error in a radiologist examination, the error was attributed to just under-reading is the technical term, just missing the finding that was present in the image. That is the most common reason for errors. But as you go down the list, it gets a little bleak because the next most common source of errors, 26%, is because the radiologist stopped looking once they found what they expected to find. And you keep going down the list, at 9%, it's because the secondary problem was distal from the primary problem, too far away. And when you have 1,000 image CT scans of the chest and the abdomen, if what you're looking for is located in one area, it can be unreasonable when a radiologist only has 3 to 4 seconds to look at each image, that they will scrutinize every region. And what we allow with our technology is to give a comprehensive scan for signs of peripheral artery disease and signs of cardioembolic stroke risk factors related to the morphology of the left atrial appendage and so on. And so, humans are not evolved to scrutinize radiographic images to the degree that we need in order to detect these secondary problems, to see the gorilla. We're not evolved to do that. And so having a second set of eyes that doesn't sleep and isn't overworked in the same way, to look at something in just 10 seconds and annotate the potential regions that may be problematic, that is a huge value to the radiologist.
Given what you just said, it seems to me that going to insurance companies and payers, really the ones that are going to benefit most if you find the normally undetected disease, would be willing to pay the most for this. And it might be the most receptive market. And I wonder what your thoughts on that are.
Well, imagine a world where when somebody has a disease that your device could treat, you got a push notification on your phone. Or when somebody had a disease that you had a medication that could treat, you were notified because it was identified. We are far from that as it is today. But if we can connect treatment to diagnosis in a way that pharmaceutical companies and medical device manufacturers, they want to connect therapeutics to diagnosis. This is how we get there.
That's interesting. You have 4 different indications that you mentioned, right? Which would indicate probably 4 different AI models. Seems like 4 times as much work. Could you focus on one? And if not, how are you going to make sure your AI models are accurate and you're not?
What's nice about our technology is that although it is 4 different models, it's based off the same platform technology. So imagine that we have all the answers.
You have to tune each model and measure each model independently.
Oh, measure that, absolutely. So measuring each model independently, each model will have its own test, training, and validation sets, and we will use specificity, sensitivity, and recall to evaluate all of those independently from each other. So it won't be the model parameters, but rather the performance on the data set we are specifically looking at. It's
key to keep in mind that your model is only as good as the data that you give it. For AAAs, for example, a Massachusetts-based Center for Thank you. Center for Data Science in Healthcare, they trained a deep AAA net model to annotate and detect abdominal aortic aneurysms. But the primary limitations of these models is the fact that there's lots of variation between hospitals, between devices. What we have is an extensive network of interventional radiologists from all across the country with different data sets that we can source from. This allows us to build robust models. Yeah, that's good.
That's good.
Thank you.
You gave the answer. Good job.